So we take great pride here at New York Presbyterian Weill Cornell Breast Center in offering people the most up-to-date and advanced techniques, certainly in surgical care, but this also includes medical oncology and radiation oncology, because nothing that we do here is done in a very specific one-person thing. It's always a multidisciplinary approach. And I think this is very good for the patient. This is good for the doctors, because the doctors have the input from the different specialties. I think the fact is that a lot of places still around the country, women who are diagnosed with breast cancer end up seeing a breast surgeon or breast specialist or a general surgeon, and that multidisciplinary approach doesn't come in. But here, as I said, at New York Presbyterian, at this Weill Cornell Breast Center site, we tried to do that, and we developed the breast center specifically so that we have the teams all available to us.
The New York Presbyterian Hospital Weill Cornell Breast Center is set up to offer patients services that encompass the entire gamut of procedures and referrals that they'll need in dealing with breast cancer and in patients that have a high risk for breast cancer.
You have to have a whole team approach, and there just aren't a lot of places that are set up to do this as it is for now. And on that basis, we do get patients from other countries who fly in for this kind of surgery because they've heard about it. I think there are other places that are starting to do this around our country and other parts of the world. And I think that as more and more surgeons understand and get trained, you're going to see more of this kind of approach to breast cancer treatment.
I think there are two issues for women, either who are at high risk for breast cancer or for those who have a diagnosis of breast cancer. And of course, one is related to the breast cancer, because everyone is fearful of illness and death, of course. But the other is the fear of mutilation. And I think, again, I think when patients go onto the internet and they might talk to their mother or grandmother, they might have seen their mother or grandmother who has had a mastectomy. And I think the images are so frightening, and the evolution in breast reconstruction is so extreme and so recent, I think, that patients are not exposed to newer images of what breast reconstruction really looks like now, and what a patient who has had a mastectomy looks like now.
The concept of using radical surgical techniques for cure of the cancer, plus the addition of the cosmetic aspects of reconstruction, is a unique idea, and it comes under the name of Oncoplasty. The Oncoplasty is defined as the approach of Onco, which is the tumor, and plasty is the idea of plastic surgery. And putting that word together is where you're starting to hear more and more about this term, because I think a lot of people are understanding, again, that this addition of approach is a plus for the patients in terms of getting them past the surgery and minimizing scars. I think the message that I like to give patients all the time is that we can fix this, because that's what people want to hear. People are devastated by a diagnosis of breast cancer, as Cecilia was as well. And you're trying to see, well, is this the end of my life? Is this the way everything's going to be different from now on? And I think one of the things we've tried to do here at Cornell has been to say, well, wait a minute, yes, you've been diagnosed, and yes, you have this potentially life-threatening problem, but we can take care of you.
I had my first mammogram in London and didn't really think any more about it. I thought it's not as bad as I thought it would be, and didn't even feel alarmed when I was called back in 2 weeks later and had a second round of mammograms and ultrasounds, and everything changed. Suddenly I had a white-coated radiologist over my head saying, there are some calcifications in your left breast. Your right breast is great, but we want to biopsy those calcifications in the left. They're probably nothing, but we want to make sure. And I staggered out onto the streets, shell-shocked. I called my gynecologist, who gave me the name of a breast surgeon, and I went to see him, and he looked at the films and he said, yes, we need to biopsy this. And I had a serous vacuum-assisted biopsy, which was brutal. It was a very deep-set DCIS, ductal carcinoma in situ, So a pre-cancer, a stage 0, that had not traveled anywhere yet, but it could have. So I opted for a first lumpectomy and was hoping that I would get it out that way. I had 2 young boys, so this is 3 years ago, and they were then, so they're 12 and 14, 9 and 11. It was intense, and I took them through it in a very lucid way. I told them that I'm incredibly lucky that they caught this potentially very sinister disease early, so let's celebrate that. And I went in for my first lumpectomy. I had never been under, and I found that very intimidating. And I had a pretty harsh anesthetist who didn't look me in the eye and just shoved the needle and put me under. And the next day they said, we didn't get it all, so we need to take your breast. And that's when it became serious. And that's when suddenly I remembered my grandmother with her teenage chest and her big lumpy arm for lymphedema. And I thought, oh my goodness, it's me. It's me. I'm 46, I'm sporty, I'm strong, I'm a mother, and it's me. And I said, why don't we go for another lumpectomy? And the surgeon was not crazy about it. He said, you have a 50-50 chance. And I said, let's do it. And we did, and they didn't get it all. And that's when my husband contacted his employers in New York and said, we have to level with you. My wife is undergoing breast cancer surgery and treatment. And they said, get her over here. We have some amazing people for her to meet.
Cecilia came to us diagnosed with bilateral breast cancer. This was based on the fact that we were very careful when we have any person who's diagnosed with breast cancer. I think it makes a lot of sense to make certain that this is the only place, or is there more disease or not, because you don't want to be focused on one breast, for instance, and then find out that something else is going on. In Cecilia's case, what we did is we had the breast MRI. We also had an outstanding radiologist who spent a lot of time being careful on the other so-called healthy breast, and much to our amazement, we found early stage disease on that side. So with bilateral breast cancer, and with her prior surgery that had shown us that she really wasn't a good candidate for breast conservation on the one side, it became clear to us that her best option was bilateral.
Hello. When I went back to London, after having met with Dr. Swistel, I basically turned my office into a kind of medical research library, and went to investigate what was on offer in Europe, in France, in Russia, in Germany, in my native Norway, and in the US. And every road led back to Alexander Swistel. The fact that he was one of the pioneers behind the single lymph node biopsy, or sentinel lymph node biopsy, which basically invented the idea of taking one single lymph node while the patient is under, instead of the usual 20-30 routinely. And this was linked to my memory of my grandmother with her painful log of an arm, you know, suffering silently for years with this double size, this walking around like this. I remember when he said, I'll take one. If I don't encounter any cancer cells in the first lymph node, well, then why go for more? And I thought that makes perfect sense. So he had that in his favor with me. I liked the idea that he teamed up with a reconstructive surgeon. So I started looking at the Weill Cornell Breast Center website, and saw who he worked with, and I got in touch with Mia Talmor, the young reconstructive surgeon that Swistel works with. And she sent me pictures of a woman my age with my frame before surgery, right after surgery, and 6 months later. And I was absolutely blown away. I mean, it looked beautiful.
Cecilia had a very novel, at the time, approach to reconstruction, in that instead of using a multi-stage procedure and going through intermediate stages to achieve the end result, we did a single-stage procedure At the time of her mastectomy, we placed implants, and in order to take advantage of the full preserved skin envelope and to use implants that she would be happy with, we added additional tissue, which is called acellular dermal matrix. It's something we use for breast reconstruction that allows us to place bigger implants in more precise locations, which really optimizes the cosmetic result that we can achieve with an implant-based reconstruction.
We are offering this what we call an inframammary approach, the incision actually underneath the breast, and through that incision underneath the breast, all of the breast tissue is removed, just as if it was a standard incision right across the chest. But this way, you minimize the scarring, and this has been a rather successful thing for us here.
The two surgeons worked in less than 4.5 hours with Dr. Swistel doing the mastectomy and Dr. Talmor putting in silicone gel implants, and along with human donated tissue, which is remarkable. It feels like it forms an internal bra, sits under the pectoral muscles, looks like thick white rice paper, and these little strips and layers are put in to cushion and kind of protect the implant, which means that I don't feel like I have artificial breasts. That's the most unbelievable thing, that I feel like myself. Sure, there is a replacement in here, but I am never aware of it. And those who love me and know me intimately say the same thing. Would never have known that these are not your breasts.
At the time of the mastectomy, we will check the tissue that we plan to leave in place. So that's the skin of the nipple and areola are checked with pathologic exam to make sure that there are no abnormal cells and certainly no cancer cells that would remain in the skin of the breast, which is one of our major concerns with clearing the cancer oncologically.
You know, for me, the key to my speedy recovery was very much early detection, meaning that I was spared chemotherapy, radiation, or even hormone treatment like tamoxifen. I'm a sensitive woman, and I know it would have been taking a real toll on my body. So I think part of certainly what you and Dr. Talmor achieved for me physically was vital, but also psychologically and emotionally. To have early detection meant that I didn't have to go through that ordeal afterwards.
Chemo, the early detection makes all the difference. It makes my ability to treat people a lot easier, and they don't have to go through all the very radical techniques of radiation and chemotherapy. Those things are sometimes very devastating, worse than even the surgery sometimes.
I think Cecilia was overwhelmed, but hesitant. You know, I think when you've been bombarded with all that information and a lot of negativity before getting here, waking up the next morning looking great and feeling great, it's sometimes too good to be true, and I think you're still very nervous for the first week or so after surgery that something will go wrong or something will happen. And I think by the time she left New York, which I think was 2 weeks after her original surgery, she was just overwhelmed and absolutely delighted. And I think really, while she was hoping for a great result and a great outcome, I think that her feeling was that her outcome had completely exceeded her expectations.
It is amazing. It is unbelievable that a woman of 46 who has breastfed 2 boys can suddenly, through a initially sinister diagnosis, end up with kind of 19-year-old perky breasts. That is quite unbelievable, and a lovely single, silver lining, a lovely silver lining to a potentially very sad story. It had a very happy ending, and it has boosted my sense of femininity, for sure.
Cecilia has done very well in terms of follow-up. Generally speaking, when you've had a mastectomy, some of the diagnostic imaging, that is mammograms, MRIs, that are often used in patients who have breast tissue still there, is just a non-issue here. There's no mammography in this kind of a situation. MRIs are often used not just to look for breast tissue, but sometimes if patients have had implants, oftentimes we want to see if the implant is still in good position. So it's really, that's the reason for having an MRI on a periodic basis.
Now I come once a year for a checkup, but I have not had any complications of any kind since surgery. 8 weeks after surgery, I was back in Hyde Park roller skiing. And I always think when I hit those roller skis with my Czech and Russian colleagues, if I had had the latissimus dorsi in my left breast from the left side of my back, and then maybe years later, having discovered the right one, I would have had no back muscle. How would I be able to ski or do anything physical? I mean, my heart goes out to women who have to maim their own body to get reconstruction. I think it's cruel, I think it's hard. It's what Dr. Swistel called the medieval shark bite. It leaves a very deep, long scar and a very, very long, painful recovery time. And I didn't have that. And I'm very grateful for that, that I didn't have to spend time in recovery for more than maybe 10 days of intense healing. Beyond that, no pain whatsoever of any kind. I find that amazing. I mean, I have replaced my chest. It's pretty staggering, pretty impressive that I haven't had a single tweak or discomfort since then.
Typically, we'd like to see patients every 6 months initially, and certainly every year. So for our patients who are overseas, we try to meet up with them at least once a year. For patients who really can't make it back to the States yearly, or for whatever reason prefer to stay overseas, we'll contact colleagues overseas and do some follow-up with them, and of course they'll keep in touch with us with respect to the patient's care. And finally, we do a lot of communication via email and over the internet, and particularly from the standpoint of the plastic surgery, pictures help a lot. So if a patient has a question with respect to something related to appearance or anything at all that might show up on pictures, they'll send me a picture and then we can communicate that way with pictures.
As we attract more and more international patients, we understand that it is a lot more difficult for them to have access to a one-on-one personal basis of interviews or even physical exams. Although I must say that with the new technology that we have, this is really remarkably changing, even as we speak. I had a recent interview with a patient on Skype from Istanbul. And it was her sister came into the office and had an iPad. And essentially, we conducted the whole interview on the iPad with this patient who was having chemotherapy, and she was interested in this type of nipple-sparing approach that we were doing. And it was fascinating to me because I could see that she could see me. We had this conversation going back and forth. And she was there, very comfortable and miles and miles away. And a lot of the questions we were able to answer for her is almost on a personal basis. I know it sounds a little odd, but I think that as technology continues to improve, people's idea of communication is changing, and so it's okay almost to have that kind of communication pattern, including things like internet access and email access, and all with the patient's permission, of course. And I think that this is a way of imparting information. We can also send some of the work that we've done, and there's brochures that can be downloaded off the internet for the patients, and so they get a lot of information this way now, much more so than ever before. So that by the time they do actually come in to see one of us here at the breast center, we already have a lot of information on them, and they have a lot of information on us, because it works both ways.